Hi everyone, I'm Dr. Hani, Senior Lecturer from University Malaysia Sabah. Today I'm going to talk about the acute renal failure. At the end of this module, you will be able to understand the function of the kidney, disease process of the kidney, causes, clinical features and complications of the acute renal failure, investigation and treatment for acute renal failure. Acute renal failure is nowadays increasingly known as an acute kidney injury, which is used by the most commonly used by the nephrologists because it is a transient shutdown of the renal function, characterized by abrupt rise in the renal creatinine function or renal creatinine concentration or reduction of the glomerular filtration rate with or without oliguria in urea. Oliguria is a urine output less than 400 ml per 24 hour. Inuria is a urine output less than 100 ml per 24 hour. In acute renal failure patient, there will be accumulation of nitrogenous and non-nitrogenous products. When you look at the kidney function, there are four major functions of the kidney: filtration, reabsorption, secretions, and excretions. When the blood is carried from the efferent arteriole in the glomerulus, some blood will be filtered and urine will be formed after passing through the Bowman capsule and tubules. Whatever not being filtered in the glomerulus will be returned back to the efferent arterioles. So if patient kidney function is damaged, the blood cannot be filtered sufficiently, then fluid will be retained in the body. Absorption, secretions, for example, like sodium bicarbonate have to be reabsorbed in the tubule. So if patient cannot be reabsorbed of the sodium or bicarbonate, then bicarbonate will be reduced in the body as well. Secretions, potassium have to be secreted from the tubules, but potassium cannot be secreted, then potassium will be retained in the body. Excretion of a nitrogenous process such as urea and nitrogen, so it will be retained if the kidney function is damaged. So as a consequence, patient will have a fluid retention and end up in the edema or acute pulmonary edema. H plus will be retention in the body as cannot be secreted. Metabolic acidosis will be a complication of that H plus retention. Sodium will be accumulated together with the fluid, so edema and pulmonary edema, heart failure. Potassium, hyperkalemia, which will be manifest as a palpitation, weakness, arrhythmia. Urea will be increased in the body if patient have acute renal failure, complicated as a uremic encephalopathy, uremic pericarditis, platelet dysfunction can cause a bleeding manifestation. When we look at the criteria for acute kidney injury, there are several classifications by Reifer. Reifer is the risk, injury, failure, loss, and end-stage renal failure. Or acute kidney injury association also have another classification, or kidney disease improving global outcome also have another classification. But basically they are the same principle. When you look at the stage 1, 2, 3 stage of a acute kidney injury patient, in risk stage 1, urea creatinine will be 1.5 times increase in the renal function, or GFR will be reduced more than 25% if it is a Reifer criteria. If urine output criteria, urine output will be less than 0.5 ml per kg per hour for 6 hours. In the stage 2, creatinine will be twice higher. GFR function is start to be more than 50% reduction, acute onset. Urine output will be less than 0.5 ml per kg per hour for 12 hours. In failure patient, urine creatinine function is more than 3 times and GFR is more than 75% reduction. In the stage 4, loss of acute kidney injury patients, then loss of renal function more than 4 weeks. End-stage renal failure, as I mentioned in the chronic renal failure lecture, loss of renal function need to be persistent for more than 3 months. Okay, let's look at the 3C for the chronic acute kidney injury. Causes. In the acute kidney injury causes, majority of our acute kidney injury causes are triggered by the prerenal causes such as hypovolemia, hypotension, heart failure, cirrhosis, renal artery stenosis, and drug-induced causes such as NSAID or ACEI. And in hospitalized patients, renal causes are also common as well. Acute tubular necrosis, acute interstitial nephritis, glomerulonephritis, and vasculitis. Post-renal causes of acute kidney injury is obstructive uropathy in patients with bilateral kidney stone disease or prostate or urethral stricture patients. Clinical features of acute renal failure is mainly presented by the reduced urine output and body swelling, generalized body swelling. When you look at the complication of the acute renal failure, once the kidney function is deranged, fluid will be retention as I mentioned earlier. So acute pulmonary edema, potassium will be retention, hyperkalemia, metabolic acidosis, uremia complications, hypocalcemia, metabolic complications, hyperphosphatemia, and long-term complication if kidney function is persistently deranged, chronic renal failure or end-stage renal failure is a complication. So when there is an acute kidney injury patient, we used to risk stratify what is the prediction of what is the likely risk in this patient to be develop acute kidney injury. If chronic kidney disease patient, 2 points, liver failure, liver disease cirrhosis patient, 2 points, acidosis patient, 3 points, nephrotoxin like NSAID, aminoglycoside, antibiotics, 3 points, and so on. If more than 5 points are more likely to develop the acute renal failure, so we can prevent the acute renal failure if we re-stratify before AKI happens. In order to diagnose the acute renal failure, we can do investigation to look for the cause, to confirm the cause, and to look for the complications. In pre-renal causes, as I mentioned to you earlier, you can do the full blood count to look for the anemia or leukocytosis in patient with the hypotension or hypovolemia patient or sepsis patient. Leukocytosis will be there. In heart failure patient, chest X-ray echo will be diagnosed as heart failure. Renal artery stenosis patient, you can do the renal angiogram or ultrasound Doppler to rule out the renal artery stenosis. To look for the renal causes of acute kidney injury, in patient with the acute interstitial nephritis, urinary eosinophil count will be high. You can do the renal biopsy to look for the glomerulonephritis or acute tubular necrosis. Urine distich or urine FEME or urine albumin ratio or urine creatinine albumin creatinine ratio can look for the kidney nephritis as well. For post-renal causes, you can order the ultrasound KUB. To confirm the acute renal failure, you can do the creatinine level or urea level will be high, or creatinine clearance level, you can do that. In the complications, ABG will look for the metabolic acidosis, bicarbonate will be low, potassium will be high, calcium level will be low, phosphate will be high, and chest X-ray to rule out the pulmonary edema as well. In the management of the acute kidney injury, we have to treat the underlying cause. In pre-renal cause, we have to hydrate the patient because hypovolemia is a cause. If it is a sepsis, you have to do the oligo-directed therapy, fluid resuscitation, and antibiotic within first 3 hours. If it is a renal cause, either glomerulonephritis or vasculitis, then you can start the corticosteroid. If patient is taking the nephrotoxin, which causes acute tubular necrosis, then stop the nephrotoxic drugs. If the acute kidney injury is a post-renal obstructive cause, then you can relieve the obstruction by nephrostomy or put the stent in the ureter. The principal management for the AKI is that you have to watch out for the intake output in chart. There are some indications for the urgent hemodialysis, such as AEIOU mnemonic, acidosis, electrolytes such as hyperkalemia, intoxication, the poisoning cases, fluid overload cases, and uremic encephalopathy cases. Then you need to go for the urgent hemodialysis. To treat the complications, if patient is having the fluid overload, then diuretic or diuresis will be walked. Hyperkalemia, you have to start using the lytic cocktail therapy, or if mild hyperkalemia, you can use the oral potassium binding resin. Hyperphosphatemia, you can use the phosphate binding agents. Hypocalcemia, you can use the calcium gluconate. And monitor all the electrolyte as well. Let's look at the case scenario 1. A 65-year-old patient who is a known case of diverticular disease, hypertension, and gout. Those other may or may not be the risk factor related to this case. Presented with a right iliac fossa pain and reduced urine output. When you see the reduced urine output, no known chronic kidney disease, then in your mind you are thinking about the acute kidney injury. Patient is on captopril and diclofenac. So diclofenac is an NSAID, non-inflammatory anti-inflammatory agent, which is a nephrotoxin as well. So on examination, patient is having the 39 fever, tachycardia, heart rate more than 100, blood pressure is still normal. So hypotension is an unlikely cause of the prerenal cause of the AKI in this patient, but temperature is high. Maybe patient is having the sepsis because temperature high, known case of the diverticular disease, and right iliac fossa pain. So diverticulitis is another condition, and patient may or may not have a sepsis. So sepsis is in your mind. Patient is taking the nephrotoxin medication, that can be a superimposed or triggering factor to be acute kidney injury as well. White cell count is the 22 CRP is high, so patient is having the sepsis condition definitely. And urea function, to confirm the AKI, they did the urea level is pretty high, creatinine level is sky high as well. So patient confirmed AKI by urea and creatinine level. The cause, most likely cause, is a sepsis according to the clinical history and blood investigation and physical findings. So what is the most likely diagnosis? Acute kidney injury, most probably secondary to the sepsis. How do you manage this case? Treat the cause, underlying cause. Underlying cause is a sepsis, so treat the oligoderylated therapy, antibiotic, and fluid resuscitation. For the renal failure, renal injury, you have to monitor the intake output chart and stop all the nephrotoxic drugs and watch out for the complication by doing the investigation of all the electrolytes. Okay, let's move on to the case scenario 2. 75-year-old man, known case of diabetic hyperlipidemia, admitted to CCU, cardiac coronary care unit, due to the inferior MI. CT angiogram showed the 100% block in the right coronary artery. Patient went for the percutaneous intervention and stent replacement. On second day of the admission to CCU, patient showed urea is high and creatinine is high. On admission, you can compare the creatinine level 100 to 180. So it is raised more than 20 to 25% raised from the baseline level. So according to the acute kidney injury, criteria is fulfilled. Abrupt onset of the raise in the creatinine function more than 25%. All other investigations are normal except patient proteinuria is present. So what is a differential diagnosis? So when you see the patient is having the acute kidney injury because of from the baseline more than 25% sudden onset of raise. So look for the 3C. Condition is a acute kidney injury. So what is the cause and what are the complications? To look for the complication, you need to look for the investigations and symptoms. To look for the cause, look at the scenario presentation. Patient 1 for the CT angiogram. So, and some more patient is a known case of diabetic. So, patient might have a diabetic nephropathy very early stage, and patient 1 for CT angiogram. So, patient might have a contrast nephropathy is a one condition. Diabetic nephropathy is another differential as well. Or patient may or may not taking the metformin, and after the contrast nephropathy, usually metformin have to stop, but patient might continue taking the metformin and one for the CT angiogram without the prophylaxis medication. So what are the prophylaxis medication to prevent the contrast nephropathy? Normally we can, radiologists can start the N-acetylcysteine and sodium bicarbonate to prevent the contrast nephropathy in high-risk patients, such as hypovolemia patient. You can hydrate early before patient go for the contrast nephropathy, and use a sodium bicarbonate and acetylcysteine. So take-home message: acute renal failure, very common in the ICU patient or CCU patient or hospitalized patient rather than the outpatient. Pre-renal is the most common cause, but post-renal is the most reversible cause of acute kidney injury. Mortality can be high. 7% cases are irreversible, and 7% cases might require the renal replacement therapy because of complicated with the chronic renal failure. Mortality can be high if patient require the urgent dialysis and patient have other organ damage as well. Thank you so much.